Hey, and welcome to the Piriformis and the Deep Six. This is really powerful work. I'm so glad that you're here learning this work. So let's jump into the anatomy and understand what it is that we're working with. So many people experience pain and aching in the buttocks, which can move into full-blown sciatica-like pain. And they're often told it's their piriformis. Maybe their yoga teacher, maybe their physical therapist, maybe their doctor, maybe their chiropractor, all sorts of folks. Maybe even you have said to them, it's got to be your piriformis. So if you're wanting to do really specific and effective work in the piriformis, that's what you're going to learn. And you want to understand the anatomy, and you want to understand the other muscles in the group that's grouped together with the piriformis so that your work can be most effective. It's also important to understand what piriformis symptoms actually are, because often just an ache in the butt gets blamed, or sciatica gets blamed on the piriformis. So let's kind of break that down in this discussion so that you can have better understanding of what you're working with and be the most effective therapist. So piriformis is one of the deep six lateral hip rotators, which means that the piriformis and those other lateral hip rotators grab onto the outside of that greater trochanter, the outside of the femur, the lateral femur, and rotate the femur in the socket so that the thigh bone is rotating externally or laterally. That's what a lateral hip rotator does. The deep six are those six muscles that lie deep in the buttocks that create that lateral rotation or that external rotation at the femur. They also contribute to horizontal abduction of the hip, which means that it kind of pulls the hip joint out and or the femur out of the hip joint. And it also, when the femur is stable, those muscles are going to pull on the pelvis. So often you'll see your clients get on the table and their pelvis is rotated a little bit. This can be a direct result of tension in the piriformis and the other deep six lateral hip rotators. So if your person gets on the table and one butt is higher than the other, you're probably pretty sure that you're going to want to, at some point in your treatment protocol, address the piriformis and the deep six, all the deep six lateral hip rotators. The muscles that make up this group, the deep six lateral hip rotators, are piriformis, the most famous one, right? Inferior and superior gemellus, quadratus femoris, and the obturator internus and externus. Now, it's helpful to understand that these muscles become continuous with the pelvic floor muscles. And so anyone who's coming to you who's being told they have pelvic floor issues, or they're also seeing a pelvic floor physical therapist, you are going to want to include this treatment in your treatment protocol because these muscles are continuous with the pelvic floor. So let's look at some different pictures and get some different viewpoints on these muscles. So in this picture, you can see that arrow is pointing right to piriformis. Notice that medially it attaches along the sacrum and then it goes out laterally to the greater trochanter of the femur. There's your piriformis. Now just below that, you'll see my next arrow is pointing to the rest of the deep six: superior and inferior gemellus, quadratus femoris, and the obturator internus and externus. You'll also see here in this top picture, we're going to look a little bit more closely at these muscles, but I want to point out here, look, there's the sciatic nerve in its typical relationship to the piriformis. About 85% of the time, that's its relationship to the piriformis. I want to also point out, here's our gluteus minimus. Now, gluteus minimus is right next to the piriformis, and gluteus minimus is also highly implicated in sciatica types of symptoms. So notice that the sciatic nerve typically weaves in between the piriformis and the other deep six lateral hip rotators. You can see that here. I blew up that section of the picture for you. You can see that sciatic nerve coming out of the sciatic foramen in the pelvis, coming deep to the piriformis, but laying superficially, so on top of those other deep 6 rotators. Here's why that's interesting. Since these muscles do the same thing in general and can draw that femur in rotation, the tension in those muscles can compress on the sciatic nerve. And this is why people say, oh, I have sciatica or I have sciatica type symptoms, but the sciatic nerve tests came back like negative. It's not true sciatica, so it must be piriformis syndrome. I'm going to say to you, and you're going to see a picture at the end of this PowerPoint where we talk a little bit more about gluteus minimus because it's often a missed piece in the puzzle. So gluteus minimus right next to the piriformis, attaches right next to the piriformis, lives right next to the piriformis, also should be good treatment of that muscle, should also be a tool in your toolbox. So when we look at this picture right in the middle, there's our piriformis again. Here's those gemelli, the obturators, quadratus femoris, all those muscles in that pocket between the sacrum or the sitting bone and the greater trochanter of the femur. So kind of filling that deep area. And that spot, that area can get really tight, can get really kind of aggravated. It can feel sometimes a little stingy. Sometimes I've heard people say like, oh, it's just so painful. And when I touch it, it hurts. Two things can happen. Either the femur is constantly rotated externally, so all of those muscles are pulled short, and then there's compression, or often the other side, the other leg is rotated externally, the pelvis is shifted, or this leg internally rotates, and those muscles are pulled long. When those muscles are pulled long, there's almost always going to be some compression on that sciatic nerve because it's squeezing the space. So both scenarios can lead to trigger points or pain around and from the piriformis and the deep 6, either a little too much external rotation or for some folks, a little too much internal rotation, pulling the muscles long. Either way, the area is off balance and your client may be experiencing some symptoms. This is directly from the Travell and Simons books, the red books, the Bibles of trigger point therapy. I love this because they have cut away the layers so you can really see the layers of tissue. Here we have the gluteus maximus attaching along the top of the pelvis, along the top of the ilium, all along the sacrum. That has been cut and reflected. And then notice that gluteus medius covering that whole side of the ilium, deep to it, gluteus minimus. And then we have our famous piriformis, which is highlighted in a darker red in this picture. And then that beautiful picture of the sciatic nerve. And then all the gemelli, obturators, quadratus femoris, deep to those, or really below those, more distal. So these muscles are kind of all lined up. They're like almost this beautiful line right in line with each other. See how these muscles attach to that posterior of the greater trochanter of the femur. So they grab a hold of that greater trochanter of the femur, pull it, and rotate it down, or rotate it externally. I want to point out on this slide the psoas attachment. Down here at the bottom right of this picture, you'll see what is the lesser trochanter of the femur. All these deep 6 muscles attach along the greater trochanter of the femur, but then distal and slightly posterior to on the femur is the lesser trochanter of the femur. That's where the psoas attaches. So I'm pointing this out because again, no muscle ever works in a vacuum, and you'll hear me saying that through all of my classes. No muscle works in a vacuum. Everything is this beautiful symphony, this concert of the tissues coming together, working together, pulling on each other, pulling on the other stuff around it. And so you cannot really isolate one muscle and work on it and expect everything to be fine. So even though you can learn these muscles separately, remembering that is all part of a symphony. And the psoas attaching on that lesser trochanter can be pulling. Now, when it pulls, if the femur moves, as when the leg goes into flexion, when that femur moves, these muscles are going to be pulled. At the same time, if there's that rotation, sometimes the psoas is contributing a little bit to that external rotation. So at some point in your treatment protocol, it's a good idea if you're treating piriformis and the deep six to give a little loving attention, gentle, kind attention to the psoas and the iliacus as well. So I wanted to point this out because this is just a great understanding to have, because piriformis and those lateral hip rotators, the sciatic nerve, typically, as we said in that first part, the sciatic nerve, both of the roots of the sciatic nerve, peroneal portion and the tibial portion, tend to come from behind the piriformis and then lay over top of the lateral hip rotators. Now, occasionally, and I believe it says here, 85% of people, the cadavers that they've seen, this is the typical regular case. Sometimes the peroneal and tibial portions are wrapping around the piriformis. Sometimes one or both, as in pictures 2 and 4, one or both are going directly through the piriformis. Now, in this case, is it necessary for you to know this to be able to work effectively here? Not really. And at the same time, it's helpful to know, because if you're doing work and this person is having really chronic, intense pain, and you've tried working all the other things, so as the glutes, maybe the adductors as well, and they're not getting better, at some point, if the pain is intolerable, and it's usually like that, like the pain gets intolerable and so much worse when they sit, then that is going to indicate that maybe they should have an MRI and have things checked out, because on occasion that their piriformis might be pierced by the sciatic nerve, and it's just something to be aware of. So more pictures, Gray's Anatomy pictures. I love Gray's Anatomy pictures because they're so clear. So in this section on the left, we see the obturators, the gemelli, the quadratus femoris. We see the piriformis. Note this open space. That's that open space for the sciatic nerve to travel through. In the picture on the right, they've put in the sciatic nerve and other branches that come off that nerve. Notice that it innervates glute med, glute min, goes down along the hamstrings. Notice that the main trunk of the sciatic nerve goes deep to the lateral portion of biceps femoris, so deep to the hamstring. And this is why a lot of folks who have piriformis syndrome or who have true sciatica do have that deep aching, deep feeling deep in the hamstring muscles. When we extend that view of the sciatic nerve, you can see that it goes all the way down. There it is, passing deep to biceps femoris, back of the knee, back of the calf, down into the foot. So tension in the piriformis and the deep six can, if it's compressing on the sciatic nerve, contribute to pain and aching along that back of the thigh, behind the knee, down the calf and foot, consistent with those sciatica pain pathways. Now, I want to say piriformis trigger points do not always cause pain and sciatica symptoms. They don't always cause sciatica symptoms. So let's look at what are the actual symptoms, the actual true pain referrals of trigger points in the piriformis, because it's not always that full-blown sciatica. The classic piriformis pain referral patterns are at the attachments. Most people, when you look So when you look at a pain referral chart, where the X's are where the trigger points live. And then where there's more red just means that more people have reported that that's where they feel the pain. It doesn't mean that the pain or sensation is more intense in those areas. It just means that more people have said, this is where I feel the pain referral from that trigger point. So you can see that the classic symptoms of trigger points in the piriformis muscle are at that juncture, at the sacrum. Notice it's kind of at that bottom curve of the sacrum. Notice that it is right at the site of the trigger point and then down along. Really notice that lateral dark red area. What is that? It's covering the lateral hip rotators. That's where the pain is often, most often. They might feel it around the buttocks. They might feel a little bit at the hamstrings. But notice that true piriformis trigger points do not cross the knee, do not go down into the calf and into the foot. Notice that classic trigger point pain referrals in the piriformis do not radiate down the outer thigh or down into the shin. That's something different altogether. So that is often caused by gluteus minimus. And I'm putting this in here because so often gluteus minimus trigger points are missed, piriformis is blamed. So I want you to understand why you're going to do piriformis work and not gluteus minimus work. Again, in your whole treatment protocol with your client, you'll probably be addressing gluteus minimus at some point. But notice gluteus minimus is called the sciatica imitator, right? Gluteus minimus is the true culprit in false sciatica. Gluteus minimus trigger points can give that ache right here. You can see in the picture right where those lateral deep 6 lateral hip rotators are. It can ache right there. And the person might be like rubbing it, asking you to rub it. You work in there. They're like, oh my gosh, yes, that's it. But if the pain isn't going away, it's not coming from there. It's more likely coming from the gluteus minimus. Notice also that gluteus minimus can radiate down the iliotibial band, the outer thigh. It can radiate across the knee, go down into the shin. If it's radiating in the butt and down the hamstring, but then it also goes into the calf, more likely gluteus minimus than piriformis. So I want you to be able to discern, am I working in the right area? Is this really what I want to be doing? Is this effective? And if it's not going to be effective, what are the other places that you want to look at? So now there are no pain referral pattern pictures of the other deep 6, of the gemelli, the obturators, quadratus femoris. There are not specific, there aren't maps that have been drawn at this date of this recording. Even Travell and Simons, no, they said there's no pictures of those pain referral patterns. Really, these are the indications that you're going to need to release those muscles. First of all, anything that you're doing in piriformis. Anything that you're doing in piriformis, you're going to also want to work on those other muscles behind the greater trochanter because they are also affecting the health, the efficacy, and the tensional system within the piriformis muscle itself. So any problems with piriformis, anything that's telling you, hey, I want to work on their piriformis, also do, and you'll learn some great techniques for releasing, getting in and releasing and clearing some tension in the other deep 6 muscles. If your client is indicating that there's pelvic floor issues, yes, you're also going to want to do some wonderful release work in those other deep 6 lateral hip rotators because these muscles are continuous with the pelvic floor. nagging pain at the back of the hip joint and lower buttocks. It can feel fiery if they're being pulled a lot or getting all scrunched up and getting dehydrated. Maybe they haven't been moving enough, or they get stuck standing with one foot turned out and the other foot forward. That one foot turned out is going to squash all those lateral hip rotators in there, and they're not going to be happy. They might get dry and sticky and kind of begin to stick together. So you're going to learn some ways to open that up and free that path and get that tissue more hydrated. Pain or sensation on internal rotation of the thigh. So if you place your client's foot on the table, they're laying on their back, place your client's foot on the table and you drop their knee medially so that it crosses over the midline of the body, essentially pulling on those muscles. If there's some pain, some resistance, some sensation when you do that, that's an indication that you want to do some work in the piriformis and the lateral 6. Also, the deep 6. Also, any sciatica symptoms, like it's not going to hurt them. They're going to love it. It's going to feel great. Even if it's not the root cause, the fact is, if a muscle, if a nerve is being compressed anywhere along its path, it can aggravate other portions of the nerve. So, you might want to also do some work in the hamstrings, also do some work in the calves, following that whole path of the sciatic nerve. And you can learn all about that in the sciatica class, which has a whole bunch of information and a bunch of muscles that we work on to fully alleviate sciatica symptoms. But if they're having some sciatica symptoms, yeah, the piriformis might be a piece of the puzzle, and it's a good idea and it feels good. No one's going to tell you, no, that doesn't feel. They're going to go, yes, get in there, get those points. A lot of folks have piriformis trigger points because most people tend to stand with their weight to one leg, tend to turn out the thighs, or maybe they cross their legs and they're constantly pulling on the piriformis and those lateral hip rotators. All of those things are going to contribute to tension in piriformis and the deep 6. So those are your indicators that, okay, yes, I'm going to do this work. So speaking of, let's get to it.